Why consider an autologous stem cell transplant in the age of novel therapies? Myeloma experts have differing opinions on the use of stem cell transplant in the age of newer therapies. In this video, you will hear varying opinions from world-renowned myeloma experts. It is essential that you discuss all your treatment options, including stem cell transplant, with your doctor.
I get challenged with this question by a lot of my patients, and I obviously love to sit down and go over my reasoning. Of course, we are all thrilled and we are all excited about all the new treatments that have come out, especially in the last 15 years or 15 to 20 years now, which was unleashed by thalidomide and of course followed by other immunomodulatory drugs and then proteasome inhibitors and then followed by antibodies and now various immunotherapeutic agents. So that is great. But why is stem cell transplant still an important part of treatment? First, two very basic things. It is safe. Number two, it is effective. It is effective on its own, where before any other treatment, before any maintenance or consolidation, when you do a stem cell transplant, more than 90% would respond, and their average progression-free survival or the duration of remission would be about 18 months to 2 years. So those were excellent results. So since then, a number of trials have been done. Some were done before the availability of these newer agents, and several have been done now with the availability of novel drugs. Basically, all the studies show that when you combine stem cell transplant with conventional treatment, whether novel or the older ones, number one, we get deeper responses, which in this day and age includes minimal residual disease negative status. Number two, we get more durable responses. So almost all the trials have shown that there is a longer progression-free survival when you combine stem cell transplant with novel agents. And in some of the studies, there is an improvement in overall survival. Since there is no single curative therapy available for myeloma, and the goal and the intent is to achieve the deepest and the most durable remission. And to achieve that goal, I think stem cell transplant is one of the time-honored, safe, effective, and in this day of cost consciousness, which actually should have been there always, is a reasonably cost-effective treatment also. So I think with all the evidence, we still feel that it is an integral part of myeloma treatment.
So I think some of the biggest questions nowadays we get asked in clinic are whether someone should or should not do a stem cell transplant, especially at the time of first diagnosis. It is a very controversial topic because historically it has been one that has been standard of care for patients that can tolerate high-dose therapy and a stem cell transplant, mainly because historically it improved survival. At that time, we did not have a lot of our novel therapies, so the decision was a bit more straightforward for patients that can tolerate a stem cell transplant. Now it's a bit more complicated because we have so many different medications, plus we have more tools such as cytogenetics and looking at response to therapy, and even increasingly so MRD testing that sometimes help us make decisions about whether an individual should undergo a stem cell transplant or not. So I tell transplant eligible patients commonly, let's look at the pros and cons of whether high-dose therapy would benefit an individual at that initial diagnosis. Certainly deferred transplantation approach has been validated without compromising survival in our most recent studies. But I think, again, kind of honing in on that theme of individualized therapy, don't feel that a particular mode of therapy is an absolute necessity for an individual. It's a discussion you should have with your doctors about pros and cons of therapy. There's plenty of patients we recommend a stem cell transplant for, but there's plenty that we do feel that can potentially keep it in reserve at a later time. So this is an important question that will hopefully continue to get more clarity as we get more tools about how to individualize therapy and choose a particular mode of therapy for a patient.
So the way we look at transplant is in the age of new therapies, those new therapies can just make transplant more effective. So we've already made transplant extremely safe. In fact, the risk score is the same as standard chemotherapy. Now what we do is then build upon that, both in the induction or the treatment before the transplant, as well as the treatment after, whether that's consolidation or maintenance therapy.
We don't have definitive evidence yet. We still know that transplant provides a strong benefit in terms of progression-free survival. There's no overall survival benefit yet, but the readouts are early. They only have about a 3-year readout. For some patients, they just don't want to have a transplant right now. There are issues, etc. But I do recommend for all patients, they should have their stem cells collected if they are a transplant eligible patient, if they're not going to go on to a transplant early on, because those patients, if they do delay and they get a lot of therapy, may have damaged marrow. So I think that it's better off getting your stem cells collected early regardless. I still recommend it right now in the current age because we don't have better data suggesting that a chemotherapy alone or chemotherapy and new drug approach is superior to transplant.
Clearly, in the old days, autologous stem cell transplant was a mainstay of treatment. It was a bridge to the next bridge. And I think what's important to recognize is it was a very valuable and important tool of old. The question is, how does it apply now? And I think what's been very rewarding is to see that we can combine novel therapies with transplant and improve outcome. But what then has happened is that these treatments have become so good. The question is, how much does transplant add? And what we saw at this meeting was that antibodies added to 3-drug platforms are revolutionizing the outcomes. At the same time, we have to be very honest with our patients that melphalan at high dose is toxic. There are side effects of the transplant itself, both in the short and the long term. And so with that, and with the impact that that has on quality of life, we have to really weigh its risks and benefits. What we saw at this meeting was a fantastic presentation from Dr. Francesca Gay in the Italian group, where they showed that in fact KRD, which is a triplet we use in the upfront setting, if you gave it for 12 cycles, it was just as good as KRD times 8 with a transplant. But what was interesting in her analysis was that in a subgroup of patients with higher risk, actually the transplant may be helpful. Now, the important point to remember is in all of this data, it's very early. So it may be with longer follow-up that we see more of a benefit from transplant, we don't know. But the flip is also true, that in those patients in whom high-risk disease was defined, we don't know at this point how they were maintained. And so I think the conclusion she drew, which is one size doesn't fit all, is absolutely correct. I think assuming just if you have high-risk disease that you must get a transplant is not necessarily true either yet, because we don't know what they were maintained with. And as one of my colleagues pointed out to me, the playing field's completely changed yet again anyway because of the antibodies. And so you may say, well, okay, well, if you've got nothing to lose, why not just do it anyway? Well, there's the sting. Because what we're realizing, as our patients thankfully live longer, that the long-term consequences of melphalan exposure are real. And they revolve around myelodysplasia and secondary leukemia. Fortunately uncommon, arguably rare, but for those patients affected, absolutely devastating. So for that reason, we need to better understand who benefits from it and who doesn't, protect those who don't need it, and at the same time optimize it for those patients who might derive significant benefit from it.
The data generated from back in the 80s and 90s showing that when you compare high-dose melphalan to conventional chemotherapy, you have better survival outcomes. But each time, one of those studies would come out, the discussion would be, well, the standard of care for myeloma is changing, so what does high-dose melphalan really help us in the context of novel agents that we are giving to patients as part of induction treatment, as part of maintenance treatment? Is it really the melphalan that's creating the value for the patient in terms of survival outcomes here or not? To date, what we know with novel agent induction and maintenance treatments, that at the very least, the depth of response and PFS is better when you give high-dose melphalan to myeloma patients in the frontline setting. Will high-dose melphalan be replaced by other cellular therapy modalities in the future? Sure, I think that can certainly happen. The goal of treatment is to get better depth of response, get patients to MRD negativity. With that depth of response being the goal, it doesn't matter how you get there. You want to get there with efficacious regimens and without causing a lot of toxicities. So even though, I'm saying that high-dose melphalan should be part of that frontline approach for patients, if we get better drugs that are safer and do the same job, why the heck not? We'll go ahead and change our treatment paradigm.
As you can see, there is still controversy even among the top myeloma specialists in the world as to if and when autologous stem cell transplant should be used. This is an individualized and personal decision. Goals of treatment should be getting the greatest depth of response and longest duration of response. Discuss with your doctor the pros and cons of transplant and your unique situation. Only then can you decide what is right for you.